Welcome to the Live Long podcast, where your health is your power. I'm Rachel Lehmanhaupt, editorial director of Live Long. Today, we're talking about the relationship between fertility and your long-term health as it relates to brain health, perimenopause, your hormones. Our guest today is Dr. Natalie Crawford. Dr. Natalie Crawford is a reproductive endocrinologist at Fora Fertility in Austin, Texas, and she's the author of the new book, The Fertility Formula, and host of her own podcast called As a Woman. Dr. Crawford will be in person at the Live Long Women's Health Summit in San Francisco, April 17th and 18th. Come see Jane Fonda, Dean Ornish, Dr. Mark Hyman, and you can buy your tickets now at livelongwoman.com. Use promo code Rachel to get $50 off your ticket. Welcome, Dr. Crawford. How are you?
Rachel, yeah, thank you so much for having me here. I'm thrilled to be here and to talk to you today.
Yeah, it's really great. It's a subject that is very near and dear to my heart, which we can get into a little bit later. But I understand it's also very near and dear to your heart. You've experienced some fertility challenges, which is something that most people don't realize about their doctor. And my first question is how did being a patient change the way you are a doctor of fertility?
Thanks for this, Rachel. It changed everything really about how I approach medicine now, and especially how I approach fertility. And it's truly the inspiration behind the book in general. But my story for people who don't know is when I was in medical training. So, to be a fertility doctor, we do 3 years of fellowship in reproductive endocrinology after a 4 year residency in OBGYN. So, I was in my residency when we were trying to get pregnant. I was an OBGYN and we experienced pregnancy loss. So, we had 4 pregnancy losses before we ended up having my 2 children. And during this time, I went through the range of emotions. The first one, I quoted medical statistics to my husband saying, 1 out of 4 pregnancies ends in loss. This is better that it ended early. I remember losing the second pregnancy while I was the chief resident in charge of labor and delivery, making decisions, having to go to the bathroom and start bleeding. And yet, you know, act like it wasn't happening and do my job and deliver other people's babies and deal with that later. And that one was much more traumatic. I was further along, but also when I went to my doctor after that one, thinking, well, something must be wrong, I was told it was just bad luck and keep trying. There's nothing I could do. And I asked for testing and I was told, no, we don't do testing until you lose more pregnancies. And even though I'd been on that side of taking care of patients, and at the time, the definition for recurrent pregnancy loss was 3 losses, I remember just feeling so disempowered. If there's nothing I can do, I had all these questions that I didn't have the answers to. Was I running too much? Was I tracking my cycles right? Were there what about alcohol? What about this? And yet I got what felt very dismissed. Kept losing pregnancies into my fellowship training. And at that time, I really started to truly understand the mental gymnastics which go on in your own journey as well. Thinking if I'm a fertility doctor who can't even get myself pregnant, what does that mean for me, both professionally and personally? And yet it gave me different insight for how the words you say as a physician can matter so much. How, as you approach something, even as simple as we may not be able to get to an answer, but we're going to try, and how much I sought after the things that I could do. Even if I can understand it, maybe there's not one decision that will make it or break it for me, but I wanted to control everything that I could. Yet, how do you do that if there's information you don't even know? And back to that basic question, if I don't know what's normal, how do I even know to advocate for what's not? So it changed how I educated my patients, how I approached it. And truly, that is a big reason why, even in fellowship, we do a big research project. We do a thesis, we have to defend it at our oral boards. And I did all of mine on natural fertility. I did it on ovarian reserve, the luteal phase, cycle tracking, vitamin levels, because I wanted questions to those answers about what makes it harder for some people to get pregnant than other people. And I'll
Well,
think.
let's
Yeah.
I want to talk about more, get into the more specifics on how you educate your
Yeah.
patients. But let's pull back a little bit and talk about the bigger question that so many people in the audience might have, which is why are so many people running into fertility problems now? Why for, the millennials, Gen Z, people coming into their 30s, why has are women facing men, families facing more fertility challenges?
I mean, Rachel, the simplest explanation is the truest is that modern life is really inflammatory. We are exposed to chronic inflammation in our food, by our daily choices, in the environment, environmental toxins. And this leads to an increase in infertility rates, both men and women. We see a decrease in sperm counts, an increase in miscarriage. We see that women have lower egg counts than they did in the past. And all of these things are not just coincidence, but to really think about the fact that we're exposed to inflammation every single day. And many of us has cultivated a life that's not meant to try to fight this in a different way. We just accept that this is what it is. So in a world that's becoming more inflammatory, inflammation is really toxic to our bodies in so many different ways, but especially when it comes to eggs and sperm, which are most sensitive cells in the body. And
Mm.
then in the same breath, women are waiting longer to get pregnant, which is great. Women should, right? Women should
And
feel
it's a good
confident.
reason women are waiting
It
longer.
is.
I mean,
We're chasing dreams,
we're
education.
getting
Exactly.
married later. I mean, what I heard in your story was I was a doctor. I was in medical practice. I did a research study on. I mean, this is something that maybe, at least I'm in my 50s, at least my mother's generation wasn't really talking about as much.
No, and I'm 44, so same. This was we infertility was one stigmatized, but so were periods and what's normal. And a lot of women sit across from me still every day and say, "Gosh, I wish I'd known that information sooner." Because when do we learn to track our cycles, or when do we learn any of this other information? So women are waiting longer, which is not a bad thing, but we know that infertility rates increase as we get older. And so we start to see that women are waiting longer. We see the world is more inflammatory. Yet, to be honest, this is what drives me crazy right now. Our approach to fertility has not changed. We
Mm.
still act like it's simply a luck narrative. We still make women and couples fail before they qualify for a standard fertility evaluation. Meaning, if you go to your doctor and you say, I'm worried about my fertility, most of the time you're hearing the message, well, just try first and see what happens. Or if you don't have success after 12 months, then we'll do some testing. Or in my case, once you lose another pregnancy, then we'll start to work it up. And I really challenge, why do we have to fail first in the world where we say infertility rates are rising? Statistically, it's not debate. When I first started in this field more than a decade ago, 1 out of 8 couples had infertility. And currently in the United States, for couples trying for their first child, it's 1 out of 5. That's a significant increase in the rate of infertility. We need to change how we approach this.
Yes. And also, I mean, and I think part of the approach is that there's been a lot of new research which is showing that your fertility experience has a really large impact on your long-term health. And so we've been sort of over the years, I mean, it hasn't been that many years since when we're having children older. And so we don't know that much. We don't have that much data, but more and more data is showing that we've treated it more like a short-term problem. And it's really more of a long-term problem about aging. So I want you to tell us how should women really think about fertility in terms of their long-term health?
You're so brilliant to ask the question because
Thank you.
there's a plethora of research showing that fertility is a health marker. And what we mean is that women who experience infertility have a higher risk of metabolic disease, heart attack, stroke, cancer, and early death. And that's a really scary thing to say out loud. And it's just not just a minor increase. Some of these, it's up to an 80% increase. I mean, it's a very large increase in the prevalence of some of these conditions. And the reason why is not that infertility causes any of these, right? If we think about infertility as a disease, it's not that infertility causes you to have a heart attack later. It's not that the medications do for treatment or anything like that. It is that there is a common underlying cause, and we're going to call that chronic inflammation and insulin resistance, that is predating both of these things. And for many women, the age of which you're trying to conceive, you haven't yet to develop some of these later chronic conditions. And if you're experiencing difficulty conceiving, I tell my patients this is a sign of underlying cellular and metabolic health that is not optimal. Therefore, that predisposes you to these later conditions if we don't use this as an opportunity to investigate and to really think about our whole body health and how we can make changes. And if we view it as a symptom in addition to a disease, this gives us the opportunity to say, oh gosh, look at me now, knowing I'm at a higher risk of a heart attack. Not
Right.
just do this to get pregnant right now as this one moment of time, but say, this is representing something in my cells that I can't see yet is not functioning in the ideal way. And I need to start thinking about how do I change that now so that I have a different trajectory than where this metabolic health parameter might go to, because we all want to live longer, but also healthier, to your point.
Somebody told me, a scientist I know named Jennifer Garrison, who's a neuroscientist, told me that really that the ovaries are sort of the pacemakers of aging. And I loved that phrase that the ovaries are the pacemakers of aging. And that, the preventative health that we can do for our fertility is sort of similar to the preventative health that we should do in life. We shouldn't treat, medical care like sick care. We should treat it like preventative health. We shouldn't treat fertility care like sick care. We should treat it as preventative health.
Absolutely. We don't wait for you to have a heart attack before we screen for, cardiovascular disease. Same thing, there's many cancer screening tests. And there's a way for us to understand how our ovaries are functioning, but they do. They're highly sensitive. They are constantly changing. We're constantly having eggs in different states of development. You have more mitochondrial density in your ovaries than anywhere else. So it is one of the ways that it takes years and years of, we'll say, chronic inflammation to build up to get to disease state. But this is a way for our body to give us a status check for how things are at this moment. Yet many of us, one, are not aware, or two, we don't know how to look into it. And looking into it is both looking at how many eggs do we have? That's called ovarian reserve. Every woman's born with a set number of eggs and runs out of them over time. But interestingly, you have a different amount of eggs available every month that's in proportion to how many you have left. So when you're having more eggs, you kind of have what's higher ovarian reserve. And when you have fewer eggs remaining, you have lower. The things that can cause low ovarian reserve, some of them you have no control over. Genetic factors, how many eggs you started with, but many of them are on this trajectory, meaning autoimmune disease, chronic inflammation, chronic inflammatory disease, insulin resistance. Those factors actually cause women to start to run out of eggs earlier. And so
Mm,
by doing a simple blood test to screen for this, it's not a test going to tell you, are you going to be able to conceive? Are you not going to be able to? But it's starting to categorize your ovarian health, saying, where are we falling on this? Because if it is low, why is it low? That's a bigger question and evaluation that women deserve answers to. And similarly, many, even patients of mine, patients who have infertility, many women have menstrual health simplified to purely being, do you have periods or are your periods regular? But a lot of the clues that our body is truly giving is that communication between the hypothalamus in the brain and the ovary is really tightly controlled. And when we do start to have chronic inflammation interfering with it, it actually starts to shift a little. But the first changes are all in ovulation, meaning it's not just I ovulate or I don't. You actually can have stages of ovulatory dysfunction. And the first one is actually having what we call a shorter luteal phase. So you just can't sustain that corpus luteum quite as long. The second one is taking longer to get to ovulation. So it just takes stronger, longer signal to get there. So these are changes to the links of the phases of our cycle, the follicular phase or the luteal phase. But in order to know that or detect it, you have to know when you're ovulating and know what's normal and know a good baseline for your own health so you can detect these changes. But so many women just use an app and they mark when their day one is, and the app's just detecting, are you having a period? And it's just using a calendar method to know when you're ovulating versus actually tracking that
right.
yourself.
Well, let's get into the bare bones of of testing. So, let's talk about age and let's talk about tests because, I understand that there are sort of some areas of fertility that are a little more settled and some that are still, sort of questioning in terms of tests. So, let's talk about, in your 20s, what you should be testing, in your 30s, what you should be testing, and also how you should think about the trajectory of, starting your family and when you should start thinking about it.
It's a wonderful question and it's a complicated answer, right? I think here's the thing that I wish all women will say in their 20s slash early 30s. If you're past your 20s, then whenever you're hearing this is still important. As I wish everybody knew what their AMH was. So this is that baseline ovarian reserve, because if it is
And
low,
that's how many eggs, right?
that is
Ovarian reserve is
how many eggs you have this month. So we can have some month to month variability. This is actually a controversial test for me to sit here and so adamantly say you should test. The American College of OBGYN says that if you do not have infertility, you should not be checking this. And their argument is just having a low egg count doesn't mean you can't get pregnant. And that's a true statement, right? Having a low egg count doesn't mean you're not ovulating, doesn't mean you'll have infertility. Similarly, having a normal egg count doesn't mean everything's great. It's not like a mark of fertility. But to me, we're learning to look at these biomarkers as they will, as signs that we're functioning normally. And when things are not normal, gives us the opportunity for intervention or further investigation. I also think it's quite a misogynistic view to say that this test doesn't matter to you, because I sit across from women every day who have a game plan, like the last part of your question, when should I have kids? And we have this mental game plan. But if we had tangible data that that plan may not make sense and we might need to do something different, I believe that women should be given the opportunity to make that decision themselves versus having time make it for it, because when it comes to your fertility it is finite, and for everybody at some point a door will shut. And so if for you that door might shut sooner, you might start for your family earlier. If you're with a partner, you might pursue single motherhood by choice, you might freeze eggs, you might have an investigation into what's underlying, and maybe you find out you have autoimmune thyroid disease, and you find some other chronic condition that you can change what that might look like for you. But all of those things can happen if you find out you might have a low AMH or low egg count, that otherwise to just say you don't have proven infertility, you haven't failed for 12 months, and therefore I don't think you can handle this information. I don't love this angle or this viewpoint. You can't make decisions on data you don't know. So I think in everybody, if having kids is on your radar, or just you want a good sense of your ovarian health, because I love what you said earlier about the ovary as the pacemaker. Ovarian health is really the key to longevity in women. So understanding where you are is so critical and important. So the AMH is still relatively newish. We only started seeing it about 10 years ago. A lot of good questions we don't have answers to about how often should you check it? How does it change? But still getting a baseline is important information in my mind. And similarly, every woman I think should know what her baseline cycle is, meaning how far apart are your periods? What day do you ovulate? Meaning how long is your follicular phase and your luteal phase? And truly, a regular cycle is one that comes within 1 to 2 days of regular every single month. When it's hopping around a week here and there, that's actually not considered normal and can be some of those subtle signs that we're talking about being abnormal. But if you know what your baseline is, one of the only, we'll say, clinical signs that you're starting to run out of eggs earlier is actually a shortening in your cycle length. So I'll use me. I'm in perimenopause now. My cycles used to be 29 days pretty regularly, and now they're every 26 days. Because when you have fewer eggs, you actually start to ovulate a little bit sooner. So your cycle shortens. But if I didn't know what my baseline was, and I just said my cycles are every 26 days and they're regular, that's going to be checked normal and you'll carry on. It's a normal part of aging, but I know I'm in this process because I know that it's different from what my baseline used to be. So the other part of this, Rachel, is that a lot of women in their 20s are just on hormonal contraception in perpetuity and they don't know, right? I don't know about you, but
Know
I
what
use
their natural cycles are, right?
exactly. So I do think there's something to be said for considering, if you're wanting this information or how to advocate for your health the best, would be, should I, take a few months break in my contraceptive of choice if that fits my lifestyle at the moment? Obviously, we never want an unintended pregnancy if that could happen for you, but saying, maybe I want to take these few months and understand what my baseline is so that I can have this information later
I mean,
on.
we're told to get mammograms every year. We're told to get cholesterol tests every year.
Yes, exactly.
But why shouldn't we also, if having children is in our future, also get fertility tests every year so we can track the data and keep, right?
100%, especially with the data we've already said. If this is an important determinant of long-term health, we know women who go into ovarian failure earlier have higher risks of dementia, heart disease, all the things too. Why should we not be given the opportunity to know that data and potentially have a different story because we're able to act on it and at least become more knowledgeable about our own bodies earlier?
What do you think the most dangerous assumption a woman can make about her fertility is?
Ooh, there's so many. But I think when it comes to it, I think probably one of the most dangerous assumptions that we can just make is that time is not an important variable. And it's not that age is everything, because it's not. Your egg quality is not just age. And you've heard me say this before, the simplification of egg quality to age is problematic, but that for all of us, the ovary will get to a point where we will not have eggs. It will not respond to medication. Egg quality does have a dependent variable on age. And so thinking about, I'll just worry about that later. I'm not going to worry about my fertility until I'm ready to have a child. That may be in conflict with your true goals if we think about, for many people, having a child is a lifelong goal. And when do we approach any goal with, I'll just deal with it later when I'm ready for that moment, right? If I said, well, I'll just worry about writing a book the day I want a book to come out, like that doesn't make sense. It takes years of planning and learning and finding the right people. So same thing if I want to be a doctor, I don't just say I'm going to be a doctor today. So for a huge life goal like having children is this idea that I'll just deal with it later, or even worse, the what medical community says, like fail first and then we'll deal with it, which is also problematic. We don't even recommend, right, testing AMH or sperm or an ultrasound until you have tried and failed. I think that's one of the hardest things. And I know how hard it is to be a woman, to be a patient, to be told this is the medical recommendation. And what we're truly asking people to do is advocate for their health and their bodies, to say, hey, well, this is important to me. Can I check my ovarian reserve? Or I
Yeah.
want my partner to get a semen analysis tested. Can we order that? And it's really having to take that agency over our own health in a medical system that is not proactive when it comes to our fertility.
Okay, so let's talk about being proactive in agency, and I'll bring in a little bit of my personal story. So when I was 37 years old, I ended a relationship, and it was very bad timing to end a relationship.
Yeah,
And at the same time, my grandmother had just died,
I'm
and
so sorry.
he left me some money. And what did I do with that money? Well, I decided to get my eggs frozen because I decided that I wanted to preserve the chance of her becoming a great grandmother and my parents becoming grandparents. So I started down the road of doing a lot of fertility tests. And one of the really interesting pieces of advice that a doctor gave me is how much to test and how much it can change decisions, but also, how getting so obsessed with it can sort of cause anxiety, and how to balance sort of the, proactive with the, doing so much that you would start causing yourself anxiety.
Yeah. I think the unknown is one of the most anxiety provoking things that we can encounter. So when I sit across from patients and we say, I don't know what's happening, I don't know what to expect, like that alone is 100% an anxiety producing process. And when you know what's happening, you know what these tests are for, you know what to expect, you know what the process of egg freezing may be, it is
Mhm.
all going to be easier down the road. I will say this on this idea when we start thinking about taking control and yet you can't control everything, but the luck narrative can be really harmful too, because if everything's just luck, then why freeze your eggs? Why do anything? Right. I like to view it as this. If we can say that, we'll use egg quality as a good example. There's a tincture of time. Your eggs are in your body your whole life. There is some wear and tear that the chromosomes will absorb over time, no matter what. But we know that chronic inflammation accelerates the rate of damage, that it changes the proteins that hold those eggs apart. It changes how the ovaries function. taking control of the factors you can is not necessarily obsessive or anxiety provoking. Like I never want anybody to obsess over every little toxin we're exposed to, for example, because we're exposed to so many. But understanding the why those things can impact your fertility allows you to be in that position of power to say, I now know I'm making the best choice. I don't have to be anxious over it anymore. So when we start looking at both, knowledge to me is always power, like getting the data about your own body, hearing the doctor explain what egg freezing is. And you can choose to do whatever you want at the end of the day, but we shouldn't be making decisions based out of fear or not knowing. So putting yourself in that place, say like, hey, I deserve to understand my body and get the testing done, sit across from the doctor, learn about it. Because only then am I in a place to say, like, this is right for me or this is wrong for me. I always encourage people to take this fertility journey with an open mind. I mean, yes, there's things that we might want and things we don't want, but life always makes us make decisions that are in conflict. So instead saying, what's all available to me? I want everybody to have patient to have all the tools and the tool belt available to them and get the testing and decide, well, maybe this was my perfect scenario, but this is my real life where I am and what's truly important to me and what can I do or what can I afford? And there's always trade-offs that have to be made.
It is a lot of it is a financial factor. I mean, I
100%.
would never have gotten my eggs frozen had I not inherited some money because at that point it wasn't covered by health insurance. And now more and more companies are covering it as health insurance. But I want to talk about egg freezing for a second because
Yeah.
egg freezing, I mean, I sort of look at it as like the pill of our generation. The pill gave us the ability to turn off our fertility. The egg freezing gives us the ability to preserve our fertility and then turn it back on when we need it. And so the question though is, what do you think about it being sold as empowerment? Like, should every woman get their eggs frozen if they know that they're probably going to have children maybe in their 40s or in their late 30s?
Here's the thing, egg freezing is not an insurance policy for your fertility. It is no guarantee. And when we simplify it to be such, we are doing people a disservice. Like we just gave a whole soliloquy about how understanding data can help you make good, educated decisions. But it is an opportunity, and I like to frame it as an investment. Just like if you're putting your money, in the stock market, like it generally will pay off, but there's some risk involved or the ROI on that, you don't know until you're ready to use it because there's future variables that we don't have all the data on now. And so if we think of it that way, it is still usually generally considered a smart decision, but we don't have all the information on it. What we know though is that egg freezing for many women, if you are not ready to have a child by your early 30s, which many people are not, the odds of conceiving start to go down. That doesn't mean it'll be impossible, but especially if we step back and say, many people don't want just one child. Often people want a multi child family. So if you're not even having that first child until your upper 30s, how old will you be? If you're wanting to expand your family, egg freezing gives an opportunity that otherwise may not exist depending on your individual scenario. There's a lot of your ovarian reserve goes into it. How many eggs you have plays into your odds of success. Your health plays into the odds of success. How old you might be when you act on this. So, for somebody who's really young, they may or may not need these eggs depending on what life throws at them. As you start to get older, the odds you're going to need them start to increase more and more. Yet the odds of success are going to be greater per cycle, not overall, but per cycle, the younger you are and the more eggs you have. So thinking about
And
it younger.
and the rates of frozen eggs, I mean, of pregnancies through frozen eggs, it's increasingly more and more successful. Babies are actually conceived with frozen eggs.
Yeah, I think it's important for people to know because I get asked this all the time, like, oh, egg freezing is so trendy now, or we just overselling it. 10 years ago, egg freezing was still pretty experimental. We did an older freezing process. We did not have as many eggs survive the freeze thaw. It was typically done only at certain centers. It wasn't even available everywhere. You had to be in a big city with an embryologist who could do it. In that time frame, so I guess that's 12 years ago, but from 2024 to now, as egg freezing is now not experimental, we have, because we've improved freezing technology, 90+% of eggs survive the freeze thaw. We have no proven detrimental outcome to, children that started as a frozen egg. That's really important data to now say success rates have improved, access has improved, more embryologists are trained. So we're able to offer it at every IVF clinic, which wasn't the case before.
That is so good to hear. And it's interesting because I actually have a friend who, a guy friend, he and his girlfriend were not ready to get married. They weren't ready to have children. So what they did was they froze embryos to
Yes.
put on, which has an even higher rate of survival, right?
Embryos do. Most embryos have about a 99% chance of survival. So compared to an egg at 90, although those numbers are dramatically similar, right? 12 years ago, I would have said a 50% chance for eggs, right? And then they're not even apples to oranges. Like we're totally playing different games here. Embryos you have more knowledge on, right? From every egg doesn't survive the freeze thaw, won't fertilize, won't become an embryo, won't always be genetically normal, won't always implant. So when we're freezing eggs, we're making a lot of assumptions that we're going to fall average. We buffer the risk by having more eggs so that if we fall below average somewhere, we can still get to where we want. That often means for a woman who is older may have to go through more than one cycle,
Mm.
and the really important thing here for the person understanding this, and we hinted at it earlier, that if all your eggs, let's say, are stored in a vault inside your ovary, every month a group of eggs is released. That group is now destined to die. Usually one would ovulate, the rest of them would die. If you're on the birth control pill, none of them ovulate, they just all die. If we're doing IVF or egg freezing, we're just trying to get that one group of eggs all to grow this one singular month in time. So your AMH, how many eggs you have this month, directly correlates with how many eggs we can get in an IVF cycle. And if that number is typically higher when you are younger, you can see how, everything is easier when you are more youthful, but you tend to have less money and less resources. And so when you're older and at the time where you might be more aware that you need this, there's a higher chance you might have to get more than 1 month's group of eggs, depending on
Thing.
when you use them. And one of the pros of embryos is that, but you might know that now because I'll know how many embryos I ultimately have. And so you can gauge more real time decisions, but it costs more money, obviously. And you need a available and willing sperm source right there, which isn't always the case for everybody if they're not ready to get pregnant. Or for many women who are not ready to pursue single motherhood, they maybe don't want to commit to donor sperm. And so some of my patients are doing 2 rounds and they're
They're
making one in,
splitting the cycle.
or they're making like a group into embryos and saving some as eggs. Whether they're trying to get pregnant now with donor sperm or with a partner, it keeps more doors open. And I
I'm
think,
hearing
yeah,
this spectrum of different choices that women are
yes.
making in terms of having kids. 20 years ago, we weren't talking about splitting cycles or single motherhood by choice or freezing embryos with your boyfriend. It's a really new world, isn't it?
It really is, and it should be viewed as exciting, but also you don't have to decide that alone. And a lot of these decisions, you may not have the data just on your own to make that decision. I saw a couple today, we had this exact same discussion, and we said, like, let's get some of the, let's check your ovarian reserve, let's find out where we are, and then let's have this discussion again to try to decide what makes the most sense. It's really personalized fertility care should be the standard of care and the name of the game. And that's really what
Personalized
we're looking for.
fertility care. So what I hear a lot of is we've said a lot of new language. There's a not.
Yes.
So what's like a sentence that you find that you say to people that maybe you wouldn't have thought you would be saying in when you were first learning to be a doctor, or or your own experience has changed. I mean, how when you deliver news about you know choices that people should be making.
Rachel, what's really interesting about this field that I didn't maybe think about when I first went into it is that if my best outcome is going to be a 65% chance of success for one genetically normal embryo, that's really great as compared to nature, right? Naturally, you're trying in a single month in your 20s, your peak odds of success are going to be 20 to 25%. So 65% is fantastic. It's also pretty far from 100, meaning that even when we do our best, we are not guaranteed success in any name of the game.
Mm.
One thing that I tell patients a lot is that I can't always control the outcome. I'm going to try. But what we want to put ourselves in the position of is that we know we made the best decisions for us with the data we had. As a patient, we feel comfortable that we had the knowledge we needed to make the right choices for us. We knew what we were doing and why we were doing it, and we had our questions answered, and that we know that we're controlling all of those factors on an individual level. To go back to the beginning of this conversation, if metabolic health impacts egg and sperm health, what are those factors? And I think, unfortunately, as a field, a lot of people have just been, just freeze your eggs, just do IVF, without maybe stepping back and saying, well, how do I have the best eggs or the best sperm? Because even in IVF, I can only work with the eggs and sperm that somebody gives me. And I will say that's why in the book, I'm gonna show it, the book, the
Yay,
fertility
the
formula,
fertility
yay.
formula.
And a large part of the book does go into what I call the 5 non-negotiables when it comes to your fertility. And you said this earlier, and I didn't get to tap into it. They're not that different than what people talk about for generalized health or longevity. It's sleep, how we manage stress, the type of exercise that we do, foods that we eat, and toxins that we're exposed to. And those 5 things, whether we realize it or not, every single day we are making choices that are impacting what I say is our inflammatory burden, the amount of inflammation we are exposed
Mhm.
to. Because life is inflammatory. We'll be exposed to more and less in the given day, but really having this mentality of I want to control what I can, and I can control my knowledge. I can control how I advocate for myself, and I can control how I set up my day and the choices that I make. And outside of that, I can't control it all. But doing those puts you in a position of power to say at the end of the day, however this journey goes, I did what I could. And I don't need to look back and ever say, I wish I had known this. I maybe would have made different decisions. That's the phrase that I am passionate about trying to eliminate from women's vocabularies.
I feel like if every woman could have that attitude about life, that would be it would be a good way. It's not just about fertility. Okay,
Yeah.
one final question, and I think we're done. But so for if a woman, if a woman listening really reframed fertility not as a race against time, but as an investment in her future, what is one, choice or one, action she should do right now?
Oh, I love it.
Mhm.
I would say, oh, there's so many. I want to go over all of them. I'll give a couple. One, the number one thing probably most of my patients are not doing that has the single greatest opportunity to improve your, we'll say, fertility and hormonal health, like health overall, is going to be getting more sleep, high quality sleep.
Mhm.
That, when it comes to a fertility metric, for every hour less of sleep you get fewer eggs in an IVF cycle. If simply your partner gets an hour less of sleep, he has lower testosterone and lower sperm counts.
Mhm.
It takes you longer to get pregnant, the less sleep you get. And more than that, the consistency of your circadian rhythm is really important to hormonal release. So
Right. So don't stay up all night having sex. No, I'm just
no,
kidding.
I mean, truly no, right? But you're also, fertility is a team sport, but also so is sleep. If you sleep in the same room as somebody, like you need to go to sleep together. One partner can't come in hours later, can't be watching the TV. Like we really need to set a really good sleep environment, which typically includes darkness, a sleep mask, a cool room, sound machine, and having that set schedule where this is the time we go to bed and this is the time we wake up, and our phones are removed from our bed so we're not doom scrolling. I would say the second thing I just want to add on there though is, no, we've mentioned it earlier, but that's cycle awareness, truly learning to
Mhm.
track your ovulation. Apps that purely have you enter cycle day 1 and they tell you when you're ovulating without any other fertility metric, those apps only accurately predict ovulation about 20% of the time. So that's yet what most women are doing. So what does this mean? This means our body temperature is called basal body temperature. There are some apps with wearables, so Apple Watch, or a Ring, Natural Cycles Band, a Whoop, that can track your body temperature. So it's not hard. It's a little bit more of a financial investment, but that can highly sensitively predict when ovulation is happening. But also there's urinary based hormone measurements to detect some of the hormones and tell you when you're ovulating, or even cervical mucus and other body signs. And I go over these in the book too, but really knowing when you're ovulating is true cycle tracking, not just when is my period coming. And women's bodies are made to give us clues about our overall health based on our cycle phases. So really learning to understand what that is for you and when is it happening.
So cycle tracking and sleep. These are the
Yes, those are the 2 to start.
that we should live by. Well, Natalie, I'm so excited to really, we will meet in person at the Live Long Women's Health Summit. And thank you for such an interesting conversation and for taking such good care of women and educating them about fertility. Really appreciate it.
Oh, Rachel, thank you so much for having me. And just want to say thank you for your own, sharing your own story and being open about some of that, because that really helps, lessen the stigma that so many women who are going through infertility struggle with. And I can't wait to meet you at the summit.
Yeah, me too. Okay, have a great one.